Now we're going to hear from Shawn Griffin, CEO of URAC, President and CEO. And Shawn will update us on the activities of URAC in this area. Shawn?
Thank you very much, Michael. First of all, I want to point out on this slide, that's got my email address on it. That's my direct email address. That's not going to some support person. I'd write it down because URAC, being able to reach out to the president and CEO of URAC is a good thing. Also, I'm a physician. I'm the first physician to be in this role, and I want to talk about our experience with measurement-based care and what we've put forth as a solution. So next slide. I may qualify for the bonus of being able to do the voiceovers when we're done with this. This all started for us when I went to the MidAtlantic Path Forward meeting for behavioral health on January 15th of 2020. I was sitting there and this graphic was put up about the reset region and it talked about the areas, and I looked at things and I'm like, okay, we're URAC. We're the largest telemedicine accreditor in the US and across the world. We do collaborative care. We have the only mental health parity accreditation that's out there, and we have network access standards, but there was this measurement-based care standard up there. And I'm like, well, we've got 4 out of the 5. Why don't we have the 5th thing? And it's something, as an old primary care provider who used to do a ton of behavioral health work back in my practices in Iowa and Missouri, where I'm like, what is measurement-based care and how can we make this roll out as broadly and as quickly as possible? Next slide. So the challenge, we've talked about the challenges. Many providers are using MBC for behavioral health. I heard some great stories from various organizations about how they're doing it. The evidence is out there. Most behavioral health, though, is in primary care. If you limit your standards, if you limit your process just to behavioral health providers, you're missing where most of the care is being delivered. And I was hearing employers talk about how measurement-based care is something that they want for their employees, and they hear about these great examples, but how do you get it more broadly? There's multiple tool sets available for measurement-based care depending upon the condition or which EHR platform you happen to be locked into. Some people are still using paper. When I was in Houston, I oversaw a primary care network of over 600 different primary care offices, and they had every single EMR that you could have possibly gotten with a coupon at Sam's Club on a weekend, or would have been given out as a free sample at the checkout line. And so I know that you can't just rely upon a technology solution. There was no standard format or independent verification. And if we built something, would it work? If you put out an optional accreditation, would it be worth the work? Because as the Joint Commission speaker talked about, if you make it mandatory, you can drive business to one of your competitors. If you make it optional and nobody shows up, what are you going to do? And so I looked at this and I said, we can do something about this. Next slide, please. I think that for a lot of the people who look at measurement-based care, there's this cycle. There is no standard payment or incentive, so there is no standard program. So there is no standard payment or program. And when it really comes to breaking that log jam, I thought, there's the collaborative care model. Well, the collaborative care model in some ways requires a closer connection. I would like measurement-based care to be in all primary care offices. I would like it to be in all offices that want to do the work that recognize what it's meant, so that as many people as possible get the best care possible, which is what measurement-based care is. So I came back and I said, guys, we're missing this one spot, and there's good evidence out there. There's other organizations doing it. Joint Commission is doing their work in behavioral health. What could we possibly do to make a difference on this? Next slide, please. So what we did is we built a program. We specifically built a measurement-based care designation. What it is it's a focused set of standards just around the core competencies of measurement-based care. If you're doing it, if you have a version of measurement-based care where you're meeting our standards, you can get this designation. We think of this as a badge of honor for those people who have committed to measurement-based care. It is specific for mental health and substance use disorder treatment, but we recognize that care can be anywhere. Behavioral health and primary care providers could qualify for this. Anywhere where this care is being delivered, if you're following the measurement-based care principles, this designation is available to you. And we think that having that designation available is the key to be able to have employers say, we understand the science, we understand, the benefits of this, we want it in our networks. And so we launched this because we say at URAC, we are the behavioral health, mental health best accreditation suite for where care is delivered. Next slide, please. So what is the designation? What actually makes it up? What are the standards? You have to be doing an evidence-based self-assessment. You have to be taking that self-assessment data in on a regular basis. And the regular basis is dependent upon what you're screening for. If you're screening for depression, you don't have to do it every single clinic visit in a primary care office, because maybe you saw that person yesterday. If they come back today, you have an appropriateness to how often you screen. You're going to classify the severity of their illness based upon the data that you get. I think this is very important when it comes to, really making sure that you've got people who are involved in shared decision making. I would use a score and I would talk to the patient about it, help them to understand it, just like I would if they had a score on their blood pressure or if they had a score on their diabetes. And then you're going to treat until you see that target improve. You're not just going to play your hunches, you're actually going to have numbers which guide your treatment. And then you're going to look at the aggregate at how you can use that for quality improvement. If you have one provider in your practice who does a fantastic job and you have another who doesn't do a fantastic job, how do you use that information to raise all boats and raise the care for everybody? So it's a really focused measurement-based care designation. We're flexible in the performance measures because, as speakers will say, there's not one set of measures out there. I mean, we can look to standard measure sets and those sort of things. And if you look at the reporting on those standard measure sets, they tend to be very small for the behavioral health issues. So we're saying that we're going to be flexible in the performance measures. And if you wanted to do this for an organization, we expect that it would take you less than 6 months and less than $10,000 to go through this. Now, honestly, if you look at those numbers and you say that's way too much for what we want as an organization, I would tell you, pull out my email address, send me a note, let's talk about this, because this is good care. When I talk about less than $10,000, I'm talking about if you had 100 docs and you wanted to implement this. I also know that doesn't fit if you have 5 docs and you want to do this, or if you're a small behavioral health provider or a community-based behavioral health provider. This has the ability to dial up and dial down. But when it comes to accreditations, that's a pretty small footprint. That's a pretty low price tag, and that's a pretty good thing. And if I'm an employer and I have a large employee base and I want to make sure they're getting the best care, I'm going to start saying, are you doing measurement-based care? Have your providers gone through this designation so that I know that someone is checking on their work? Because we can do all the things that we want to and we can think that we're in great shape, but at some point you got to step on the scale and you got to see what the numbers are. And that's true for treatment of depression. That's also true for saying that you're doing something that is the best practice. Next slide, please. So we think that this also serves as a roadmap. If you go to our website and you say, what is measurement-based care designation? We have our standards listed on our website. This can be a roadmap for providers to figure out what they need to do for measurement-based care. There's fantastic research out there. I love the research. I love the experts who speak on it. But how do I take this and turn it into practice? It's really demonstrating value-based care and data-driven patient care, annual reporting of measures that we're going to help to drive care over time. When you have reporting of measures to an independent accreditation organization, you overcome some of the hesitancy that providers have when they have to report their measures to a payer, because they're concerned that the payers might be using their measures to cut them out of the network or those sort of things. And we want this to be more broadly adopted than that. And we think that by building this, as the MidAtlantic Path Forward said, they could use something in this space. We're hoping that the employers say, you're right, you built it, we're going to show up for it. Next slide, please. I also want to remind everybody that when we talk about our measurement-based care designation, this can go along with any of these other programs that we have. And we have mental health and substance use disorder parity programs. We're the only ones who offer that type of accreditation, but we also are one of the leading telehealth accreditation programs. So it can go with that. But don't forget about all the other things we do. We have patient-centered medical homes. We have health plan. We have, pharmacies and those sort of things. We also do opioid stewardship, which is another area of concern. But my last slide is the one where I really sort of put the bow on it. Next slide, please. URAC built it. Will anybody buy it? If we build it and nobody buys it, it's really tough to make it mandatory. If we build it and everyone adopts it, it's really easy to use it to move along as we broaden this. It needs to be for everybody who's providing care. It needs to include primary care. It needs to improve the behavioral health care space. It needs to be anywhere. And that's what we think we built. We think it's simple. We think it's effective. We have rolled it out. We have had interest from multiple organizations, and everybody's going, will I get paid more for it? Does it get me in the network? And they're sort of waiting. And so I think the more that we get endorsement, like Optum just sent out an endorsement letter recently talking about how they're planning on asking about this as part of their network contracting strategy, that's the kind of support that I would hope to get from employers and from payers as we move this forward. And with that, I will turn it over.
Thank you so much, Shawn.